Hi everyone, and welcome to this next block of teaching on XS 2902. So for the next couple of weeks we're going to be looking at respiratory physiology, and the structure of the sessions is going to be this week we're going to have a recap of respiratory anatomy and lung volumes. So it's probably been a while since a lot of you have covered this in your first year, so I think it's always useful to start this block of teaching with a quick recap of the structures of the lungs and some key lung volumes. Then next week we'll look at control of respiration, so we'll look at central control and peripheral control of breathing. We'll then go on to respiratory gas laws and gas exchange, and then post-Christmas, the first session back, I will be uploading two lectures. One is on respiratory responses to exercise, and the other one is on respiratory conditions, health and performance. And the reason why I'm going to upload those two lectures simultaneously is because for your next assignment, you'll have the choice of two questions. One of those questions is based more on exercise performance, and one of the questions is based more on exercise and health. So it'll be looking at lung disease such as emphysema, asthma, things like that, and how that affects exercise and performance, but not in a sporting context like the other question. And then lastly, you should already have this because we've done the practical on Douglas bags. So if you refer back to Teams and Streams, then you should already have the recorded lecture on Douglas bags and respiratory calculations. Okay then, so let's get started with this week's session on respiratory anatomy, a recap. So as outlined before, the aims of this specific session are twofold. Firstly, to recap on the anatomy of the respiratory system, so the conduction zone, the respiratory zone, the different structures of the lungs, etc. And then at the end of this session, we'll have a look at some of the typical lung volumes and lung capacities, and we'll define each of those. Okay then, so if we start with a global overview of the respiratory system, then we can split it into two distinct areas. So from the trachea to the terminal bronchioles, this is what's known as the conduction zone. So within this zone, there's no alveoli and no gas exchange with the blood occurs. From the respiratory bronchioles downwards, that's what's termed the respiratory zone, and that's what contains the alveoli, and that's where all gas exchange occurs. So within this conducting zone, so pretty much from the nasal cavity downwards, we've got the nasal oral cavity, we've got the pharynx and larynx down into the trachea. This then branches off into the left and right lobes, primary bronchi, then into the left and right secondary bronchi, and then we get down to the tertiary bronchi and bronchioles. And all this structure is simply a means of directing external air into the body, into the system, and down into that respiratory zone where gas exchange can start to occur with the blood. Okay, if we start with the first of those structures of the conducting zone, the nasal cavity and the pharynx and the larynx, they serve several functions. So one of the first ones is to warm and moisten air as we breathe it in. So you may have noticed that on cold days, or particularly if you're away skiing or something like that, and it's cold and you're at altitude, then your throat can feel quite dry at times as you're breathing in. And part of the reason for that is as we breathe that cold air in, we need to warm it and we need to add moisture to it, and that moisture comes from these nasal cavity and the pharynx and the larynx. So it's pretty impossible to freeze the lungs for this reason. So by the time it's got a couple of centimeters down the respiratory tract, then it's picked up sufficient moisture and sufficient heat to prevent freezing of the lungs. Another function is olfaction or smell. So the structures within the linings of the nasal cavity that are sensitive to different smells. It also acts as a resonating chamber for speech and sound. So as you're speaking and you're bringing air in through the mouth and through the nasal cavity, then that can alter the way we sound and the way we speak. So that's why if you pinch your nose, then your sounds different, your voice sounds different, because you're not getting as much air going through the nose, and therefore it affects the resonance of that noise. It also is involved in immune function. So within the nasal cavity, there's a number of different structures. So firstly, we've got these conchae, which are these irregular processes here. So you've got three main ones: the superior, middle, and inferior conchae, or concha. Sometimes you see it spelled AE, sometimes it's just spelled with an A. Both the same thing. And they help to filter out foreign particles and help to reduce the potential for respiratory tract infections. So this is partly why people who have nasal problems and end up mouth breathing to a greater extent tend to have more upper respiratory tract infections, because there are less structures within the oral cavity to help filter out these foreign particles. Another part of the immune system that's found within this region is called nasal goblet cells. So these are specialist cells that produce and secrete mucus. And they're found in the epithelial lining of the nose, the larynx, and the trachea, and to a lesser extent in the bronchi. And this mucus coats the airways, and it helps to trap foreign particles that are inhaled through external air, and then it's collected by this mucus and it's gotten rid of by the lymphatic system. So either it drains into the lymphatic system, or we snot it out and we get rid of it that way. And then lastly, another function or another element of the immune system is called cilia. So cilia are very small hairs that line the nasal cavity, and again their function is to trap particles, but this time they carry them away to the pharynx, so this area, and they're cleared by either swallowing or spitting it out. So again, at this time of year, you probably noticed there's a lot of coughs and colds going around, and people are a little bit more snotty than they normally are, and that's essentially because of the germs. These systems can become overwhelmed, and therefore we can get an excess of mucus building up, and that's why sometimes you can get what's called postnasal drip, where you feel that snot dripping and mucus dripping down the back of your throat, and that's because there's too many bugs and viruses and particles for these structures to cope with, and therefore you get an excess of mucus building up. And if we don't hydrate sufficiently enough, then it gets really thick, and that's when we start feeling really clogged up. Another function of the nasal cavity, pharynx and larynx, is the equalization of air. So in the middle ear, you have three small bones, and they're sensitive to pressure, and the function, so the bones are the malleus, the incus, and the stapes, and they help to transmit sound into the middle ear. So for example, when you dive in, for every 10 meters that you dive, the air pressure in the middle ear is halved. So one way that we can combat that is by pinching our nose and blowing. And what that does, it forces air into the eustachian tubes and helps to bolster the pressure. So otherwise these bones tend to rub on each other and they start to cause pain within the ear. That's why one when you're diving, but also when you're in an airplane and you're coming down, because the aircraft is pressurized, and it's pressurized to, if I remember, it's about 1600 meters, so roughly about 3,000 feet. But as you come down to land, then that pressure is reduced. So therefore the pressure, particularly if you've got a cold again, then that pressure within the middle ear can be significantly reduced, and those bones rubbing against each other is what causes the ear pain. Now, there's a number of different methods you can do. Something called the Frenzel or Frenzel technique, where you can take bigger gulps like this, and again that helps to push air into the middle ear. Or you can, as I said before, just pinch your nose and blow it. Chewing again helps to open up these eustachian tubes. So if we look at the nasopharynx, which is this bit here, then we can see there's a little opening there, okay? And that opening is the opening to the eustachian tubes, okay? So that's where the air goes. Now you've got to be careful not to do it too hard, because if you forcibly pinch your nose and blow too hard, then you can pop your eardrums, okay? And then lastly, the last function of this structure is for the passageway of food and air. Okay, so you've got the glottis, which we'll come on to in a second, which closes the airway off and pushes air down into, food down into the stomach, and then when we're breathing, that opens up, so it opens up the lungs. Okay, moving on from the pharynx, we have the trachea, and this sits anterior to the esophagus. Sometimes you'll see esophagus spelt with an O at the beginning, sometimes you'll just see it spelled with an E, depending on UK or American textbooks. But the trachea is this long structure here, and it's made up, or it composes of around 15 to 20 C-shaped cartilage rings. Okay, and the purpose of these cartilage rings are to provide support to the trachea, because if we didn't have them, when we inhale, because it's a relatively thin membrane, as we inhale, it would just collapse in on itself. So these cartilage rings sit kind of like that along the length of the trachea, and they provide rigidity to that structure. In addition, it also houses the larynx, or more commonly known as the Adam's apple, and the Adam's apple contains the vocal cords. So the vocal cords are made up of folds in the mucous membrane, or what we call either, sometimes they're referred to as twin inward foldings, or sometimes more technically they're known as invaginations. And these vibrate, so when we're talking, they sit horizontally across the larynx, and when we talk, they vibrate, and that's what creates the sound. So when we're singing, and I'm not going to sing for you now, but when we sing, they can vibrate as much as 450 times per second. Okay. And then lastly, within this structure, we have the epiglottis. Okay. So again, as I briefly mentioned on the previous slide, the function of the epiglottis is to direct food down into the esophagus and into the stomach. So when we're swallowing, we've got the airway here, and we've got the esophagus posterior to the airway. So when we're swallowing, the epiglottis, which is essentially just a little flap of skin that sits at the back of the throat, that closes off, so it contracts. So there's muscles within the walls around the epiglottis. They contract, pulling it downwards, so that essentially seals off the airway to the lungs, and then food can pass into the esophagus and down into the stomach. When we stop swallowing and we start to breathe in, these muscles relax, and the epiglottis relaxes and comes up again, and subsequently opening up the airways so that we can start to breathe again. Now, as adults, we can't breathe and swallow food at the same time. When you're a baby, or certainly newborn babies, for the first couple of weeks, up to about, I think it's about 2-3 months, they can. Okay, so they can breathe and swallow at the same time. Okay. Okay, so when we talk about the lungs, we generally primarily just assume their function is for breathing and equalization of oxygen and carbon dioxide across the lung and the blood-brain barrier, the blood capillaries. But they may have another surprising function. So platelets or thrombocytes are colourless blood cells that help blood to clot and prevent bleeding. And until recently, it was believed that these were predominantly produced by the bone marrow in a process called hematopoiesis. However, a 2017 study from the University of California, San Francisco, found that more than half of the megakaryocytes, so these are the cells that produce the platelets, that produce the thrombocytes, were actually produced in the lungs. So what this means is that there's essentially a huge reservoir of blood stem cells residing in the lungs, or being produced by the lungs, that could act as a possible backup system in case bone marrow function becomes impaired. Now, one thing to note about this particular study was that it was done on mice, okay, and quite often we know that research that's done on mice and rats doesn't always translate to humans, but the researchers of this, the authors of this particular piece of research strongly believe that similar processes may actually be present in humans as well. Okay, and just finishing off on the last slide, there's been a number of other studies since 2017 that have supported that work, that also show that the lungs have this large production of megakaryocytes. And interestingly, as a result of COVID, there's actually quite a number of studies that are coming out more recently that have shown as a side effect of COVID, there's an increase in an excess production of megakaryocytes, both within the lungs and in the bone marrow. Okay then, on to the lungs. So we've gone through the trachea, the pharynx, the larynx, and now we're down into the lung themselves. So first of all, as we get down to the bottom of the trachea and the bronchi, we split into the secondary bronchi, which are these structures here. So you've got the right lobe and the left lobe. These, my arrows are a little bit off there, but these large structures here are the primary left and right bronchi, and these smaller but still reasonably substantially large structures are the secondary bronchi. So the whole lungs themselves, each lung, is encased in what's known as a pulmonary membrane. Okay, and this has a number of different layers. So it has the outer layer, or the parietal layer, and this is very sensitive to pain because it has a lot of nerve endings within the lining of it. We then have the inner layer, okay, which covers the entire surface of the inner lungs themselves, and this is technically termed the visceral layer, or the visceral pleura. That doesn't, this isn't sensitive to pain because it lacks that sensory innervation. And then within that, those two layers, so it's a double layer of membrane, and within that forms the pleural cavity. Okay, so within the pleural cavity is a fluid called pleural fluid, which is produced by the intercostal arteries, and that again helps to lubricate the lungs. So when we breathe in, and the lungs expand, those two layers are separated by a small layer of pleural fluid to prevent that friction, and that is constantly being produced and reabsorbed by the lymphatic system. Okay, so the lungs themselves are divided into two lobes, the right lobe and the left lobe. And the left lobe has two separate elements or fascias, and the right lobe has three lobes or separate lobes separated by these fascias. So the fascias, these lines going across here. And it's because of these fascias that it's possible to have surgery to have part of the lung removed and we can still survive. So if you were to take this part off here, then we could still survive quite easily without that element. Now, the reason why the left lobe only has two lobes, or the left lung only has two lobes, is because it has to accommodate the position of the heart. So what we see is this quite large indentation on the left hand side, and that's what we call the cardiac notch, and that's where the heart sits, just there. And you can see from this notch there, we can see the back portion of the lungs. So the lungs don't just sit on the front, they're not just flat, they do go round, okay, so they fill up the whole of the chest cavity. Okay, so subdividing the lungs down even further, and remember at the minute all this is still the conducting zone, there's still no gas exchange occurring, but each lobe is divided into bronchopulmonary segments, okay, and there's 10 segments per lung. So these are the bronchopulmonary segments, these slightly larger structures here, okay, all these. Get my pointer up again, sorry. There we go. So all these structures here. So each segment contains lobules, which are these, okay, and they contain lymphatic vessels. So these green lines of green vessels are the lymphatic vessels, and they carry lymph or interstitial fluid from between the cells containing bacteria back to the lymph nodes to be destroyed. They contain pulmonary arterioles, so that's these slightly larger blue vessels, venules, okay, it's the smaller red ones, and then we've got branches of the terminal bronchioles, okay, so this is kind of this bit here, okay, before we get into these structures. So all this is still the conducting zone, as I said, so it's simply passing the air from the external environment down into the mouth, the nasal cavity, the trachea, the larynx, the pharynx, primary, secondary lobar lobes, bronchi, and then into here. From here, this is where gas exchange finally occurs. So these are the respiratory bronchioles, okay, and from this point down is what we term the respiratory zone, and this is what actually contains the alveoli. So each respiratory bronchiole consists of around 2 to 11 alveolar ducts, which are these slightly larger structures here. Well, I say slightly larger, the tiny in comparison to the other structures, but these vein-like, tube-like structures, at the end of which we get the alveoli sacs, okay, which are these, and this is where that gas exchange starts to occur. Okay, so in terms of the structure of the alveoli themselves, first of all, alveoli is the plural, alveolus is the singular. So each alveolus is a cup-shaped pouch, and it's composed of two primary types of cells. So the first is type 1 alveolar cells, and these are the main type of cell that make up each alveoli, and they're composed of simple squamous epithelial cells. Okay, so squamous simply means scale-like, and so these are very, very thin single cell layered cells, and they make up the bulk of each alveolus, and this is the main site of where gas exchange occurs. Secondly, we've got type 2 alveolar cells. Sometimes these are referred to as septal cells, and these produce and secrete a complex oily secretion of phospholipids, or approximately, which is made up of about 85% phospholipids, about 5% neutral lipids, and then the remaining 10% is made up of lipoproteins. And this surfactant coats all the alveolar walls, and this prevents the alveoli from sticking together following expiration, and then allows them to reinflate during the next inspiration. So essentially it acts as a lubricant to prevent the lungs from collapsing. So together with elastic fibers, these provide the ability for the alveoli to expand and inflate, and this is what we term compliance. So if you have a small change in alveoli pressure and that results in a large change in lung volume, this represents high compliance, and this is advantageous because it means there's less work or muscle contraction within the lungs that's required per breath. There's also additional cells called alveolar macrophages, or these are dust cells, so sometimes you'll see them referred to as wandering macrophages, and these basically just get transported around each alveoli, and they pick up any remaining debris that's managed to get past the other structures. So as we breathe air in, we've mentioned the cilia, the nasal goblet cells, all that lot that help to pick up foreign bodies and dust particles, but some of it will get down into lungs. So we've got this final system, these wandering macrophages that help to collect any remaining dust particles. In terms of thickness of the alveoli, so the alveolar and capillary walls form the respiratory membrane, and they are around 0.2 to 0.5 micrometers thick, or thin, should I say. And because of this thinness, I mean, it's essentially one cell layer thick, that allows for rapid diffusion of gases across that membrane. The lungs themselves have a relatively large surface area, so if you were to take the lungs out and dissect them and lay them flat, it will cover approximately 70 square meters. And in terms of how many alveoli there are, typically there's around 300 million per lung, or within both left and right lungs. So if we look at this schematic of a single alveolus, we can see these blue bits, these are the type 1 alveolar cells, so they're forming the bulk of the cells. We've got the respiratory membrane there, which we'll come on to in a second. We've got these septal cells, so this is what's producing the surfactant. Then we've got the pulmonary capillaries, and within there we've got the red blood cells themselves. These are the macrophages, the wandering macrophages, so these are what go around the alveolus, mopping up any debris. These little purple lines here, these are the elastic fibers that allow the alveolus to stretch and recoil. And then we've got the capillary membrane, the respiratory membrane here. So within that, we can see the red blood cells. So we've got O2 diffuses from the alveolus, this side, into the red blood cells, and CO2 diffusing the other way. I'm not going to go into that in any more detail in this session. We'll save that for when we go on to gas exchange in 2 weeks' time. But then we'll see within this membrane itself, there's again a couple of layers. You've got the capillary endothelium, again single cell layer thick. Then you've got what's called the basement membrane, again extremely thin layer, epithelial basement membrane, which is on the opposite side to the, so that's on the alveolus side. These are on the pulmonary capillary side. And then you've got the type 1 cells again, and you've got interstitial space. Okay, so in respiratory physiology, the ventilation perfusion ratio, or VQ ratio, is a ratio that's used to assess the efficiency and adequacy of the matching of two different variables. So V, ventilation, which is the air that reaches the alveoli, and Q, which stands for perfusion. Don't ask me why they chose Q and not P. But Q stands for perfusion, and that's the amount of blood that reaches the alveoli via the capillaries. So ideally, we want a VQ ratio of 1, which would mean there's a matching of ventilation to blood flow to the capillaries. Typically, on average, alveolar ventilation is around 4 litres per minute. So normal pulmonary capillary blood flow is around 5 litres per minute. So this would result in a VQ ratio of 4 to 5 or 0.9. So pretty close to that ideal of 1. However, this ratio does differ throughout the lung, though. It's not the same consistently throughout the different portions of the lung. Okay, so in an upright lung, the ventilation perfusion ratio progressively decreases from the apex to the base, so from the top to the base. So the middle and the lower zones are better perfused with blood. So we can essentially split the lung into 3 sections or 3 zones. We've got zone 1, zone 2 and zone 3. So in zone 1, perfusion, so blood flow is relatively absent. Zone 2, perfusion is sporadic, and in zone 3, perfusion is consistent. And that's because it's a gravity-fed system. It relies on gravity. So if we look at this graph here, we look at VQ, and it works backwards. So this side is the bottom of the lung, this side is the top of the lung. So in the alveoli in the upper lung portions, they receive moderate ventilation and relatively little blood flow. So we can see in these upper parts, ventilation is okay, but perfusion is relatively low. So we end up with a resulting RQ of around 2.4. So approximately 90% of the air is moved into the blood. However, in the lower regions of the lung, the alveolar ventilation is moderately increased, but blood flow is greatly increased since, as we said before, it's gravity dependent. So therefore, the resulting ventilation perfusion ratio in the lower portions of the lung is closer to that ideal of 1, it's 0.8. Okay, so in essence, the upper zones are overventilated and underperfused, and the lower zones are, I wouldn't say underventilated, but they're only moderately ventilated and overperfused. So the key relationship to remember is when ventilation perfusion ratios increase, ventilation is greater than perfusion, and when the ventilation perfusion ratio decreases, perfusion is greater than ventilation. Now, when we're exercising, we get a mismatch in this VQ ratio. So typically, VQ during exercise of moderate to high intensity is around 5. And that's because ventilation is anywhere between 100 and 200 litres per minute, but blood perfusion is much lower. It's 20 to 40 litres per minute. Okay, so there's three processes involved in respiration: pulmonary ventilation, external respiration, and internal respiration. So pulmonary ventilation is simply the process of getting air from the external environment into the lungs, and this is composed of inspiration and expiration. So inspiration is a passive process, and expiration under normal resting conditions is generally a passive process. However, when we start to exercise, we'll see on the next few slides, it does become a more active process as well. External respiration, despite its name, is involved within the lungs, and that's simply the process of exchanging air from the alveoli into the pulmonary capillaries. And then internal respiration is from the capillaries to the tissues themselves, into the cells. Okay, if we look at inspiration first, then during inspiration, as we breathe in, thoracic volume is increased by contraction primarily of the external intercostal muscles and the diaphragm. So the most important of these two is the diaphragm, and this is innervated by the phrenic nerve. So as it receives innervation, it stimulates the diaphragm to contract. So in its resting state, we can see faintly on this diagram, it's domed up. As it contracts, it flattens, and that increases the volume within the chest cavity. So that volume change is only around 2 to 3 millimeters of mercury, but that's enough to draw air into the lungs. So this is related to Boyle's law. So we'll go more onto gas laws in a few weeks. But Boyle's law simply states that at a fixed temperature, the volume of a gas is inversely proportional to the pressure exerted by that gas. So in other words, if you increase the volume of the area, in this case our lungs, then the pressure will be reduced. If you decrease that volume, as in expiration, then the pressure will increase. So we need to have a pressure gradient in order for air to flow from the external environment into the lungs. And air, liquids, whatever, will always flow from an area of higher pressure to an area of lower pressure. So when we stimulate the diaphragm and the external intercostals, we get this enlargement of the chest cavity, reducing pressure by 2 to 3 millimeters of mercury, which is enough to stimulate a lower pressure gradient inside the body than the outside of the body, and therefore air will flow in through the mouth and nose and then down into the lungs. Conversely, expiration is essentially the reversal of this process. So the diaphragm, stimulation of the diaphragm is withdrawn. We see this doming up again, as we can see here in this other diagram, and we get a relaxation of the external intercostal muscles, and therefore we get a reduction in the volume of the chest cavity, and again that is enough to increase the pressure gradient to slightly higher than the external environment. So without trying to think about it too consciously, you may notice when you take a breath in, a normal tidal breath, not during exercise, just resting breath, as you exhale, the chest cavity drops, but then prior to you taking your next breath, it'll ever so slightly increase again. So the chest will drop and then it'll rise fractionally. And the reason for that is because we have to create this increased pressure inside compared to outside. So that'll force the air back out to the external environment. Now we'll talk more about it in third year XS3 103 module, but this is one of the reasons why it becomes harder to breathe when we go to altitude, because there's a reduction in the pressure gradient because of a reduction in the environmental barometric pressure. Okay, so during deep inspiration, such as during exercise, the inspiratory muscles contract more forcibly, and they're also aided by additional muscular contraction. So firstly, we have the scalene muscles, which are these muscles that run alongside or down the sides of the neck, and these connect the first two ribs, so they help to pull the upper chest up and out. We also get contraction of the pectoralis minor muscles, and these connect to or link ribs 3 to 5 with the scapula, and they help to pull the mid part of the chest up and out. And then we also get further contraction of rectus abdominis and the transverse abdominis muscles. Now, during expiration, as I said before, at rest that's primarily a passive process, but during exercise it becomes a more active process. So whilst we get contraction of the external intercostals during inspiration, we get contraction of the internal intercostal muscles, which are these ones which run kind of slightly vertical to diagonal underneath the ribs. So we get active contraction of those, which help to more forcibly and more rapidly pull the chest cage back down. And then also we do get contraction of some of the back muscles as well. So you may have noticed sometimes when you're exercising particularly hard, or you've been exercising for quite a while, and then you put in a last big effort towards the end of a race, say, you sometimes get a bit of a backache. And part of the reason for that is because we've got these accessory muscles, these back muscles that are starting to help with active deep expiration. So you've got contraction of the multifidus muscles, which run longitudinally along the spine, and we also get contraction of the quadratus lumborum muscles, which again run from the lower ribs down to the top of the pelvis. Okay, so internal and external respiration reliant on a number of different factors to be effective. So first of all, there has to be a partial pressure difference or a pressure gradient. So as I mentioned on one of the previous slides, in order for air to move from the outside environment into the lungs, there has to be a negative pressure gradient. So the inside pressure, the chest pressure, has to be lower than the external environment. So at sea level, normal barometric pressure is about 760 millimeters of mercury. So within the chest during inspiration, that needs to be around at sea level, around 758 millimeters of mercury. Very small, but enough to get the air to be drawn in. Other factors that influence it is surface area of the lungs. So the greater the surface area of the lungs, then the greater the potential for gas exchange. Diffusion distance. So that's the distance between the alveoli and the capillaries. So that will largely depend. The greater the diffusion distance, then the lower the gas exchange, or the lower and the slower the gas exchange. The closer the diffusion distance, then the more rapidly that diffusion will occur. Now, within the muscles, that largely depends on tissue fiber types. So, as we know, type 2 non-oxidative fast twitch type fibers have a less mitochondria than slow twitch fibers, but they also have a greater diffusion distance. Okay, so the capillaries sit a little further away. I mean, we're still talking very close, but they sit further away than the muscle cells than in slow twitch fibers. So therefore, for fast twitch fibers, that's why they tend to fatigue, or part of the reason they fatigue more rapidly, because gas exchange is impaired because of that increased diffusion distance. Conversely, the opposite occurs with slow twitch fibers. Surface tension of the alveoli. Okay, going back to one of the earlier slides when we talked about the role of surfactant and compliance, so it kind of links to the next point on the slide. If there's a limited amount of surfactant for reasons such as lung disease. Emphysema is a classic one. So within emphysema, there's a reduction of surfactant that's produced. Therefore, the lungs, the alveoli, tend to stick together. So there's a decrease in lung compliance. And one of the things, I'll talk about this in the session post-Christmas, but one of the characteristics of emphysema is kind of a barrel chest appearance. And part of the reason for that is because as we breathe in, or as the patient with emphysema breathes in, the lungs don't recoil as effectively, so they tend to stay somewhat expanded, and that's why you get this barrel-chested look. That again ties in with elasticity, air resistance. So again, lung disease, asthma, things like that will compromise internal-external respiration. And then lastly, the molecular weight and solubility of the individual gases. So whilst oxygen is important, we can't live without it, it has a lower molecular weight than carbon dioxide. So typically carbon dioxide is around 24 times more soluble than O2 in fluid, in our case in blood. Therefore, the net result is carbon dioxide diffuses around 20 times faster than O2 into and out of the cells and into and out of the blood. Okay, so this schematic here just illustrates the changes in partial pressure of oxygen and partial pressure of carbon dioxide within the various different structures within the pulmonary system. So within the alveoli, partial pressure of O2 is around 105 millimeters of mercury. So again, this is all at sea level. It's very different when we start going to altitudes, but we're not going to get onto that in this session. So within the alveoli, PO2 is 105 millimeters of mercury, and PCO2 is around 40 millimeters of mercury. They then diffuse across that capillary membrane into the pulmonary veins, where PO2 decreases ever so slightly by about 5 millimeters of mercury to about 100 mmHgs. PCO2 is relatively consistent, stays around 40 mmHgs, and that stays pretty stable all the way through the left atrium and ventricles, all the way through the systemic arteries until we get to the cells within the tissue, the muscles themselves, at which point CO2 diffuses into the muscle cells and O2 diffuses into the muscle cells and CO2 diffuses out of the cells back into systemic veins. At this point though, PO2 drops markedly to around 40 mmHgs, so millimeters of mercury is abbreviated to mmHg, and PCO2, because we're producing more of it, increases in pressure to around 46 mmHgs. And again, that goes through the right atrium, left ventricles, and back to the pulmonary arteries, where the whole process starts all over again. Okay, so that's the structure of the respiratory system side of this session done with. What we're going to do now is going to look at some of the lung volumes and capacities. So there is a number of different lung volumes, and I'm going to give you the definitions of these in a second, but we can combine a number of these volumes to create different capacities. So first of all, So first of all, we've got inspiratory reserve volume, IRV, okay, which is this green bit here. So inspiratory reserve volume is simply the amount of air that can be inhaled above tidal volume, okay? So typically that is around 2.5 litres. Tidal volume is the volume of air inhaled and exhaled in a single breath. So as you're resting and relaxing, breathing normally, that is tidal volume. Expiratory reserve volume is the amount of air that can be forcibly exhaled beyond tidal volume. Okay, So that's this bit here, typically around 1.5 litres. And then residual volume, which is the last of the volumes, is simply the amount of air remaining in the lungs even after forcible maximal expiration. So as I said, we can combine a number of these volumes to create different capacities. So we've got inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. So inspiratory capacity is maximum volume of air drawn into the lungs after normal expiration. So as you breathe out normally, so at the end of a normal tidal breath, you forcibly breathe in as much as you can. So that is vital capacity, that is tidal volume plus inspiratory reserve volume. Okay, so this schematic colour codes it for you along here. So you can see the green and the purple. So that's this, all of this is inspiratory capacity. Functional residual capacity is the volume of air remaining in the lungs after expiration of a normal breath. So as you breathe out, that's what's left. So we've got tidal volume plus expiratory reserve volume. Okay, as we can see there. Vital capacity is the largest possible tidal volume with maximal effort. Okay, so that's including inspiratory reserve volume, tidal volume, and expiratory reserve volume. So as you forcibly breathe out and then forcibly breathe in as much as you can, that is your functional residual capacity. And then lastly, total lung volume, as its name would suggest, is all of the above. Okay, inspiratory reserve, tidal volume, expiratory reserve, and your residual volume. Okay, so minute ventilation, okay, is the total volume of air inhaled and exhaled per minute. So it's simply frequency multiplied by tidal volume. So frequency of breaths multiplied by your tidal volume. So in an average adult, we tend to breathe around 12 breaths per minute, and each tidal volume, as we can see here, is about half a litre or 500 millilitres. So if we take 12 times 500, gives us 6,000. So in other words, 6 litres. So typically our minute ventilation at rest is normally somewhere between 5 and 6 litres per minute. Okay. One thing that we need to remember though is around 30% of tidal volume remains in what's known as anatomical dead space. So when we were talking earlier about the conducting zone, i.e. the parts of the respiratory system which doesn't involve gas exchange, that is what we can also term anatomical dead space. Okay, so some of this tidal volume will reside in here. Okay, so within the trachea, the larynx, etc. Okay, so roughly about 30% of it. Again, thinking forward to third year module, XS3 103, and looking at physiology of scuba diving and things like that. This is partly why, this anatomical dead space is partly why snorkels are a certain length. Okay, right, I think about 14 or 15 inches and about 3/4 of an inch in diameter. Because if it was any longer, then it would increase the anatomical dead space too much and it would be simply too hard to breathe. Okay, so there's a number of sex differences between males and females when it comes to lung volumes and lung capacities. So whilst tidal volume is pretty much the same, around half a litre per breath for males and females, there are considerable differences for the other volumes. So inspiratory reserve volume is around 3.1 litres in males compared to about 1.9 litres, so almost just over a litre difference. Expiratory reserve volume, again, around half a litre difference, and then residual volume. Not too much difference, only about 0.1 of a litre difference between the sexes for that. Similarly, for lung capacities, there are some notable differences. Again, quite often they're around a litre difference, or vital capacity, typically around 4.5 litres in males compared to 3.1 litres in females. Inspiratory capacity 3.6 versus 2.4, and so on. But total lung capacity is probably the biggest difference, so it's around 6 litres for males and 4.2 litres for females. Obviously, there's exceptions to every rule. There are some females, particularly highly trained females, endurance trained females, who will have larger lung volumes and larger lung capacities to, say, sedentary males, but by and large there are generally accepted sex differences between males and females. In terms of what the reasons for these differences are, well, I'm not going to go into those in this session. They will form part of the double lecture first week back after Christmas, but it's important that you maybe start doing some reading around this topic now in preparation for your assignment, your report, depending on whether you're going to do the question that's based on sex differences, or whether you're going to do the question that is based on lung disease. So speaking of which, as well as sex, age, stature, mass, race, etc., disease, in particular lung disease, will also have a significant influence on these volumes and capacities. But whilst I'm not going to get into too much detail on that here, again, that will form part of the double lecture, I do want to very briefly have a quick look at COPD, so chronic obstructive pulmonary disorder. Okay, so COPD, chronic obstructive pulmonary disorder, is something of an umbrella term that's used for a number of different pulmonary conditions, which includes asthma, emphysema, bronchitis, amongst other respiratory diseases. And this can affect lung volumes in a number of different ways, but primarily it's related to residual volume. So if we look at this schematic at the bottom, if we look at total lung capacity, vital capacity, there's very little difference there. Total lung capacity is greater in normal healthy individuals compared to those with COPD, but vital capacity is largely unchanged. What does differ, though, is the functional residual capacity. That is smaller in COPD patients because of this smaller inspiratory capacity. Okay. The other big difference is residual volume. So residual volume in COPD patients is generally much greater than that is in healthy patients, and this is due to hyperinflation of the lungs. So because the elastic recoil of the lungs is impaired due to COPD, whatever the cause of that COPD is, then it causes them not to deflate as effectively. So going back to a couple of slides ago, when we talked about surfactant and lung compliance and elasticity, that all feeds into the condition of COPD. So because we have less surfactant, they don't inflate and deflate as much, but there's also a significant reduction in the elasticity of the elastic fibers within the alveoli as well. So as they breathe out, less air is expired, so we get a greater residual volume there. Okay, if we look at the responses to exercise then, if we take this side here first, this is normal resting value, so you got maximal expiratory volume, and you got maximal inspiratory volume, and then we've got a tidal volume here. And then we've also got ventilation values at the bottom. So minute ventilation at rest, around 5 to 7 litres per minute. As we start to exercise, during light exercise, we can see that maximal expiratory volume is not as great as it is under voluntary expiration at rest, and that's simply because we're not trying very hard. Slightly more than what it is under resting conditions, normal relaxing resting conditions, but still relatively small. Ventilation increased up to about 25 litres per minute. As we increase up to moderate exercise intensity, ventilation is increased again, around double, up to about 50 litres per minute, so almost 1 litre per breath. Again, we can see that the expiratory volume is still not particularly high, okay, because we're not forcibly breathing out at this rate too much. But what is increased is our inspiratory volume, still not reaching anywhere near a voluntary maximal inspiratory volume because we're not exercising particularly hard. It's still only moderate exercise. Under heavy exercise, minute ventilation, VE, is up to around 85 litres per minute. And then inspiratory volume is markedly increased over moderate exercise, and as is our maximal, as is our expiratory volume. But both are still not close to our maximal values. Now I'll come on to this a little more when we're looking at exercise responses, respiratory responses to exercise. But ultimately this shows that respiratory parameters are not what we would term a rate limiting factor or performance limiting factor when it comes to exercise. There are other, probably more cardiovascular factors that have a greater impact on performance limitations as opposed to respiratory. Now when we look at trained and untrained, so again these are both at maximal exercise. Untrained maximal ventilation is around 110 litres per minute compared to around 160 litres per minute in trained, and in endurance trained athletes that could be slightly higher still, around 170, 180 litres per minute. But there is a difference in the profile of these different volumes. So for untrained individuals, they tend to expire more forcibly during maximal exercise than untrained individuals. But the inspiratory volume is lower. Now, one of the reasons for this may be, as we see here, I mean, if you look at the actual vital capacity of these two, it's very similar. But the difference is the elite or trained athletes have a much greater inspiratory volume compared to expiratory volume. Okay, and that may come down to this ventilatory rate, the fact that they're breathing more rapidly. They're not inspiring to the same degree as non-trained individuals. Okay, so the very short expirations, but very large, long inspirations. Okay, so when we looked at the lung volumes and capacities between males and females before, that was looking at it purely from a resting state, not during exercise itself. So a number of researchers have speculated that females see greater impairments in pulmonary gas exchange compared to males during exercise. So this study looked at that. Now, first of all, the title says, does gender affect human pulmonary gas exchange? That really should say sex, because they were simply looking at males and females. Don't mix the two terms up. They are different. Sex refers to simply male and female, which is what you'll be doing for your assignment, so make sure you refer to sex differences. Gender is something that you assign to, so whether you identify as male or female or gay or lesbian or whatever, that is not what this is looking at. This is looking at simple sex, male-female differences. Okay, so that aside, this study looked at sex differences, and they used what's called a multiple inert gas elimination technique. In other words, they looked at how quickly different gases are eliminated from the lungs. So they took 8 females and 7 males who were matched for age, height, and importantly, VO2 max. Okay, so all participants, both males and females, had the same mean VO2 max of around 48 millilitres per kilogram per minute. Now, one thing it doesn't do here is present the standard deviation, so we don't know what that is. I would assume that because they were fitness matched, anybody who fell outside one standard deviation from the mean, they were probably eliminated from the study. Okay. So they were tested during normoxic conditions and hypoxic conditions during cycle-based exercises, and they looked at resting lung function between the sexes and during exercise. So what they found was, despite there being lower diffusion capacity for carbon dioxide and oxygen in females, there was no induced abnormalities or differences in gas exchange between the two sexes when matched for age, stature and aerobic capacity and lung size. So what they concluded was that lung size and level of fitness is probably more important than sex per se in determining whether pulmonary gas exchange is impaired or not. Now, when we come on to the lecture post-Christmas on sex differences during performance, then we'll look into this in a lot more detail, because there are certain respiratory mechanics that do differ between males and females, which can lead to a compromising exercise performance. Okay, so during resting and low intensity exercise then, so at rest, the VE and the VE to VO2 ratio ranges from about 23 to 28 litres of air per litre of oxygen consumed. Okay, and this changes very little even during mild low intensity exercise. And for healthy individuals, they'll maintain this ratio up to around 55% of VO2 max. Now, for well-trained individuals, that can be significantly higher. That can be up to sort of 80-85%, if not more, percent of the VO2 max. But ultimately, this ratio indicates that the control systems for breathing are matched to the body's need for oxygen. So this indicates breathing economy. For moderate to high intensity exercise though, ventilation increases proportionately to exercise intensity, as we said on the previous slide, up to around 55% of VO2 max for most healthy individuals. But once we get kind of into the moderate to high intensity exercise, so around 55 to 70% of VO2 max, slightly higher for those better trained individuals, then VE increases disproportionately to exercise intensity. And this can be indicative of ventilatory threshold. Okay, so the point where there's a disproportionate increase in minute ventilation. Sometimes this is referred to anaerobic threshold. Now, strictly speaking, they should not be used, those two terms, ventilatory threshold, anaerobic threshold, shouldn't be used interchangeably. They are two separate parameters. So ventilatory threshold simply refers to ventilatory mechanics, whereas the anaerobic threshold refers to metabolic parameters, i.e. increase in lactic acid production. However, for the vast majority of individuals, they tend to occur in or at around the same time point, hence why there's often the two terms are used interchangeably. And this stems back way back to research that was done by Wasserman and co, who found there was a causal link between the two. Now, that doesn't always occur, but for the vast majority of people, they do. So around 55 to 75% of VO2 max, then we start to see an increase in lactate production and lactate accumulation, and therefore that's an increase in CO2, which subsequently stimulates the chemoreceptors, and that's what causes this increase in ventilation, or this disproportionate increase in minute ventilation at that point. Okay, we can see that quite clearly from this graph here. So we've got running velocity along the bottom, along the x-axis. We've got minute ventilation on the primary y-axis, and we've also got secondary y-axis here showing O2 uptake. So we can see during these early phases of exercise, minute ventilation and oxygen uptake tend to track each other reasonably parallel, reasonably closely. Okay, so as we've said before, they're well matched. But then we get to a point where we see this disproportionate increase. So we see this break point, as it's often termed, in minute ventilation. Okay, and that increases. So if we were to draw a line of best fit through there, we can see that there's this break point quite clearly here. It's not always that clear. Sometimes it's quite subtle, so it takes a bit of practice to get used to identifying where these break points occur, and we'll come on to that in a future lesson. But we can see oxygen uptake continues to increase in a relatively linear manner. Okay, eventually it's going to peak or it's going to plateau, but VE increases disproportionately. Okay, so that's what we can term VT. Now you've got VT1 and you've got VT2. Okay, so VT1 is the first break point, VT2 is the second break point. Now, I'm not showing it on this graph here, but sometimes what you'll see is VT1 is relatively, let me try to see if I can draw it. Let me see. So sometimes it's going to work. What you'll see is something like that, and then you'll see something like that. So this will be VT1, and this point where there's a secondary break in linearity will be VT2, and this is where we see a significant accumulation of lactic acid occurring. Okay, let's get rid of those. Okay, and then during maximal exercise then, and again these are values for average Joe, so maximal minute ventilation may exceed around 120 to 125 litres per minute. For highly trained elite level endurance athletes, that can get close to 200 litres per minute. We see high breathing frequency, so around 50 breaths per minute. Again, for highly trained endurance athletes, that can be almost 60, one breath per second. And we see an increase in tidal volume from around half a litre to 2.5 litres. Again, that can be even more, that can be upwards of 4 or 5 litres for trained athletes. Okay, so in terms of VO2 max and the rate limiting factors, then there's a whole chain of events that can lead to or compromise VO2 max. So we've got ventilating of the lungs, which we talked about before, the matching of ventilation and perfusion, so that VQ ratio, gas mixing within the lungs, diffusion across the membranes, blood transit time through the capillaries. Okay, so that is under normal conditions, resting conditions, blood transit time is roughly, I think it's about 0.7 milliseconds to transfer through the pulmonary capillaries, but even during maximal exercise, that's reduced to about 0.3, 0.4 milliseconds, but it's still enough time for gases to equilibrate across the membrane. Peripheral resistance, which we've mentioned previously, blood volume. Okay, the greater the blood volume, then the greater the potential for VO2 max, not always. Similarly, red blood cell count and hemoglobin levels, heart rate, stroke volume, capillary concentration, mitochondrial density. So you can see there's a whole host of factors that can ultimately limit VO2 max. It's not purely again about how much red blood cells you have, how much hemoglobin, and how much mitochondrial density. All these other factors will feed into it. Okay then, so that's this first session on respiratory physiology done. Here's a couple of recommended textbooks to go and have a read over these what we've covered today in a little more detail. In terms of your first assignment, I'm not sure whether Rob has gone through that with you or not yet. If not, he will be at some point soon. But start to have a read around on sex differences in respiratory parameters and lung disease and how that affects respiratory performance as well. Okay, I think I've already put some reading up on Blackboard for you, so please make sure you go and have a look at those and then check the reference list in those papers and go and do some further reading. Okay, thanks folks.